Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. When I think about rheumatoid arthritis, my mind goes to the joints, to the synovium, the swelling, and the erosions that can occur. Rarely, I think about the lungs or the heart and how these organs can sometimes be affected by rheumatoid arthritis. But the brain? Today, we're talking about something that's often invisible and yet deeply impactful: cognitive dysfunction in patients with inflammatory arthritis. What does brain fog mean for our patients? How much of it is due to inflammation or depression, perhaps medication side effects, or just the weight of living with a chronic illness? To help us unpack this, I spoke with Dr. Patricia Katz, who spent years studying cognition, disability, and quality of life in people with rheumatoid arthritis. Dr. Patricia Katz is professor of medicine and health policy at UCSF. She's a past editor-in-chief of Arthritis Care and Research and now co-editor-in-chief of ACR Open Rheumatology. Her research focuses on patient-centered outcomes, mental health in rheumatic diseases, and how factors like sleep, stress, and physical activity influence disease and quality of life. She's authored over 300 publications and received numerous awards from the ACR and ARP, recognizing her research and mentorship. This conversation is about how we understand our patients' minds, not only their joints. Enjoy. Patty, welcome to the show.
Thanks for asking me to be here, John.
So I'm super excited to talk to you about something that rheumatologists, I feel like, don't think about enough. When I think about extra-articular manifestations of rheumatoid arthritis, I'm thinking mostly about the lungs or how it can affect the heart. But I've never really thought about how rheumatoid arthritis can affect the brain. What drew you to sort of first study this intersection of rheumatology and cognition?
It was really an accidental interest. I was working on a study of disability and predictors of disability in both RA and lupus. And we had at the time, a young neuropsychologist working with our group. And because of that, and because we know there are these associations of cognition with lupus, we were going to add this cognitive battery to the study. And we figured, we'll have the same assessments for everybody. And so it was really sort of accidental. There had been some research at that time, which I really wasn't aware of. There had been a few studies published about impaired cognition in people with RA. The first one I think that I'm aware of was from Simone Appenzeller, and that was in the early 2000s. But I really didn't know about that at the time. So it was an accidental finding. And then we had a nursing doctoral student who came in and was interested in the issue, and she did some of our first analyses, and then it sort of went from there.
So can you just briefly talk about the scope of the problem? How common are cognitive issues in rheumatoid arthritis as compared to, people that don't have rheumatoid arthritis that are of similar ages?
Well, that's a really good question. I don't have a good answer because there haven't been that many studies. If we think about cognitive complaints, we know that we don't see that much evidence of cognitive complaints in people with RA. If we look at the study that came out of our group, again, it was relatively low. If we look at the brass cohort, they had about 10% of the people who had cognitive complaints. And then we had a study that came out of Forward, which is another cohort study of older adults with an average age of 72, and using the PROMIS scores for cognitive symptoms, and their scores were average.
Got it. And when people report cognitive issues, what are they reporting? Like foggy brain? Is that or problems with memory? Or what is it that people sometimes report?
Again, In RA, we don't really know. I mean,
Hmm.
everybody, I think, is sort of familiar with the complaints of brain fog or bad memory in people with lupus. But in RA, again, from the BRASS study, it was problems with memory or finding words.
Hmm.
The PROMIS measures look at being able to sort of find words, maintain the train of their train of thought, that kind of thing. But when you're measuring cognitive symptoms, it's more specific, so you have more
Hmm.
specific functions.
So, Patty, it seems like people with rheumatoid arthritis aren't necessarily reporting that they may have cognitive dysfunction. But what is it that you find when you actually measure cognitive function among people with RA?
Well, you're right. We did find that there is no association between what people report in terms of their cognitive function and the objectively measured function.
Hmm.
Every study that I'm aware of has found, though, that there is a significant difference in some aspect of cognitive function between people who do and don't have RA. Well, RA and normal controls. The areas, though, that are affected depend on what measure they've used and how they've described it and how they define it. So it's really, we know there's something there, but it's not clear exactly where the issues are.
Hmm. I mean, what do some of these studies report? Like, what are some of the deficiencies that patients with RA are shown to have in some of these studies?
Tanya Mead led a systematic review of the studies, and I think that was published in 2018. So it would be, studies that were finished before that time. And what she found was verbal function, memory, and attention.
Hmm.
But the individual studies, you can take a test, and some people describe what it's measuring as, X, and somebody else will say that it's Y. And so it's really difficult to combine all of the results. So I applaud her ability to do that.
Interesting. And what do we think about is the biologic underpinning for those differences? How does RA affect the brain? Is it the medications we use? Is it something about the inflammation? Is it something else? What do you think is driving it?
I think that disease activity probably does play a role. There have been studies that show that people with cognitive impairment do have usually greater disease activity by,
Hmm.
traditional measures like DAS and some of the components of DAS, the ESR and CRP.
Hmm.
There have been at least one study that showed that there was a greater prevalence of rheumatoid factor positivity or ACPA positivity. There's also a study out of Mayo, the Mayo study, clinic study of aging, that showed among their cohort that they had MRI data on that there was more abnormal cerebrovascular pathology in
Hmm.
the in people with RA who had some evidence of cognitive impairment. So it's probably multiple things, but we also see associations with depression, and we know that depression is more common in people with RA. And I mean, you could say, do they arise from a similar source, or is the depression driving the cognitive impairment? Because, cognitive impairment is sort of a hallmark of depression in
Hmm.
some sense. So it's hard to tease that out. And I'm not aware of studies that have actually tried to do that.
Super interesting. So you're saying that there's a correlation between cognitive dysfunction and disease activity, so that, patients that have higher ESR, CRP, DAS28, more disease activity maybe have worse cognitive function. And also you mentioned that there may be some cerebrovascular issues with people with RA that, as much as we focus about, the cardiovascular risk, that chronic inflammation is bad for the heart because of cardiovascular, issues and plaques and whatnot. maybe the same thing is happening in the brain.
Yeah.
And what about medications? I'm sure giving people steroids aren't good, isn't good for their cognitive function. What do we know about medications and how that may affect cognition?
Not much is the short answer. The more complete answer is that there's a little bit of evidence that steroids might play a role. I think one interesting thing is that many of these studies that were taking place in the mid 2000s or even a decade ago would involve people whose disease may have developed earlier and maybe even pre-biologic. So eh, I think that we don't have good current data on medications is the short answer.
Such an interesting point. So that if we have this data on people that may have had uncontrolled rheumatoid arthritis for 30 years, and now that we have biologics, maybe cognitive dysfunction may be less common because we're doing a better job of lowering that CRP, ESR, and preventing all the chronic inflammation. Do we know anything about like biologics and their relationship with cognitive dysfunction?
No, we don't.
Okay. Yeah, I would imagine, I guess, in theory, if you do a better job of treating your patient's rheumatoid arthritis with biologics, maybe it spares them some of this cognitive impairments. And I think it's worth repeating something that you said, this idea of depression, right? Because I think from medical school, you learn that depression can cause sort of like a pseudo dementia, right? That
Right,
one of the things when you interview people that appear to have dementia, you have to make sure that they're not depressed because that would be a reversible cause. And what you're saying is people with RA seem to have an increased risk of depression. And is that the risk factor for cognitive dysfunction?
right,
And it's sort of hard to say which way does that flow, right?
right.
What came first? Super interesting. So, given, this understanding, what should we be doing in our clinics? Should we screen everybody with RA about cognitive dysfunction, or should we, because it seems like people aren't necessarily reporting these issues.
I don't think it's feasible really to screen everybody for cognitive dysfunction, and if you did, you're gonna get a very global measure from something like the MoCA or the MMSE, and that's probably not gonna be very helpful. I think that in the clinic, if people are not reporting symptoms, then I mean, I think the first thing I would suggest is to which is what you would do ordinarily, is their disease well controlled? I mean, that's as a rheumatologist, the thing that you're focusing on primarily. Depression is something else we've talked about, and we don't really know how much of cognitive impairment can be attributed to depression, but that's something else I would think about. There are short screening measures for depression, but I'm sure as a clinician, you probably have had to deal with that many times. The other two things I really think are important is to find out if people are getting any physical activity and how their sleep is.
Mm, mm,
So I'm going to pivot a little bit here to lifestyle issues.
love it. It's not just about our biologics, right?
Well, our lifestyle activities do affect our biology, maybe not biologic medications.
Yes. Talk more about that. So sleep and exercise and relations to cognitive function.
So there's a very clear and consistent relationship between inactivity and cognitive problems. And it's not just in RA, it's pretty much in older adults or period. So we know that a lot of people with RA are inactive. And I think that cognitive function is not the only thing that improves with physical activity. It's like the whole system works better. So I think that would be one really important thing just for overall health, but cognitive function would definitely be a consideration there. And I did see one intervention study that was looking at that, and it did show positive results in RA.
So improving exercise improves cognition.
Yeah, I wouldn't even use the word exercise. I just think because exercise is sometimes off-putting to people,
Mm,
just activity.
physical activity.
It's physical activity, just moving around, and that can be walking or whatever makes people feel better,
Right.
but physical activity.
Okay.
And then sleep. So, sleep problems are also associated with poor cognitive function, and sleep apnea in particular can be because, when you have obstructive sleep apnea, you have these periods where the brain's not getting enough oxygen, and so that can affect cognitive function. We did a study recently where we did home measures of sleep, including 2 nights of sleep monitoring with a sleep apnea screener, and we found that over half of our sample had sleep apnea symptoms that were moderate or worse.
Wow.
Yeah, and so I think that that's something that's probably under-recognized and can have an effect on cardiovascular disease and depression as well as cognitive function. So, I think that's something else in the clinic to think about. People may not know they have sleep apnea. They may need to ask their bed partner if they're, waking up with snorts and loud snoring, but those are the things that I would suggest because screening for cognitive function, I just don't think is feasible.
Got it. So, I mean, you're seeing it like we need to optimize, these things for everybody, right?
Right.
Optimize disease activity for everybody, make sure that everybody's getting enough good, high quality sleep, physical activity for everybody. Any thoughts about diet and do they have a role in mental function?
Well, there's a little bit of work on obesity.
Hmm.
Diet itself, unless people are having symptoms that are keeping them awake, I'm not sure that there's any dietary issues per se. It's would be more on a body composition based perspective. Again, obesity can be associated with depression. It can be associated with poor sleep. It's usually associated with not getting enough physical activity. So,
Good point.
yeah,
So you mentioned a lot that there's a lot of sort of limitations in the way that we sort of measure cognition and sort of our ability to tell, is it the chicken or the egg? Is it the RA driving the depression, driving the cognitive dysfunction, or is the depression just driving the cognitive dysfunction? How do you think we should try to overcome some of those challenges in the way that we conduct research about cognitive function in patients with RA or any other rheumatic disease?
common metrics are important. So when we have different studies or looking at different measures or different domains, it is just a little piece of the puzzle. And I think it would be helpful to try to define domains that need to be measured. What are the best ways to measure those for starters? And there's some work going on in lupus around this issue, but I'm not aware of anybody that's really doing it in RA because cognitive function hasn't really been an issue, hasn't been identified as a major issue in RA. So I think that's one thing. Another one is to use sort of a common language when we're talking about it. So you'll see things like, oh, visuospatial processing or visual fluency. And I think that we need a common language so that when we are talking about a domain, we know what it means and how it's measured.
Hmm.
And finally, I think that we really need to define what are the important covariates to think about. So we do need to include depression when we're talking about cognitive function. We do need to look at things like activity or even education, because a lot of time, many studies have shown associations of cognitive function with education
Hmm.
or even with income. And clearly, we need to control for age or at least stratify by age. Then we get to the whole issue of language of birth and that kind of thing. So, I mean, that goes way beyond, I think, where we want to be right now. But those are the top areas I think we really need to have to improve what we know.
And Patty, what do we know about the role of stress in patients with rheumatoid arthritis and how that may also impact cognition? I know that you've been studying this as well.
Yeah, stress. I think the impact of stress is often underappreciated
Hmm.
because stress can affect inflammatory activity. And if it's affecting inflammatory activity, one would think that it would probably have an effect on disease activity. Again, I personally know more about this in lupus than I do RA, but I think there's some similar things that could be going on. Stress is also associated with depression, and symptoms may be worsened when people are under stress. They may report more fatigue or more pain, so pain thresholds may decline. So, with all of that, and if it's associated with depression, there may indeed be a role. But again, you've asked a question that I don't think there's an answer to.
I mean, it sounds like such a complex topic to study because there's so many variables that may play a role in cognitive function. So, if you had to give some recommendations for rheumatologists who are seeing these patients in clinic, what would they be? What would you recommend that we be sure to do, in those 20 minutes that we have with patients?
Oh, 20 minutes if you're lucky, right? Well, I think disease activity is always going to be your top
Got
priority.
it.
And I
Okay.
think that goes a long way to increasing inflammatory processes that might be happening. It's pretty much the things that I just mentioned is that if people have cognitive complaints, then that's one conversation, and then you can sort of explore depression, ask them if they're getting any physical activity, ask them how their sleep is. And if you don't have complaints, but maybe in your interaction, you're seeing that maybe people aren't clicking the way you think they should. I mean, you could explore those same kinds of issues. Realistically, being aware of some of the lifestyle issues, I think that could make a difference in people's cognitive function as well as their health overall. It's probably the strongest message at this point.
And is there or what is the role of like neuropsychiatric testing for patients with RA? When should we refer patients for that?
I don't think that's clear. I mean, again, if you saw that someone clearly was having cognitive problems in your interactions with them, then that's, I would say, is a signal. Other than that, I don't think there's a clear time to recommend that.
Okay. And what would you say to patients, if who want to make sure that they're healthy and don't want to have cognitive decline as a result of their rheumatoid arthritis? What would you recommend for them?
Well, I'm going to get back on my lifestyle horse here and say get some physical activity, make sure you're sleeping well, go out and see people, have some social interactions, make sure that you're using your brain in positive ways.
Right.
Whether it's a hobby. I mean, social interactions are another thing it's important to encourage.
Absolutely. Yeah. And just one last question, Patty. What do you think are the biggest unanswered questions? So for listeners out there who are, fellows or interested in research projects, like what do you think are the biggest unanswered questions about some of these issues that you brought up?
We still don't have a clear picture of what the cognitive deficits are and what's causing them. And so I think that's a big unanswered question. We have some hints. There's some research out there and there's some hints, but I think we could do more and to build on what's there to try to progress rather than open a whole new, start going off into some tangential area. And I also think that the issue of what to do about it is important. And so interventions looking at some of these lifestyle issues in particular, because not only do those not cost very much, people generally like to have some agency over their health. And so that's a positive issue as well. And if it ends up being disease activity, then do medications make a difference? So
Super. Patty, this has been a really interesting conversation. As I mentioned at the beginning, this topic of cognitive function among my patients with rheumatoid arthritis hasn't really been at the forefront when I evaluate patients, but certainly now it will be. And I really appreciate your time today and certainly all the research that you've done in this field and really hope that you continue driving this forward for the time to come.
Thanks, John.
Well, that was Dr. Patricia Katz sharing what we know and what we don't know about cognition in rheumatoid arthritis. I think for me, the takeaway is pretty simple but profound. Inflammation doesn't stop at the joints. It can touch every system, even the brain and the mind, and it can even affect a patient's sense of self. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. Show notes for this and all other episodes can be found at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, be sure to take care of your patients' brains, in addition to their joints. And of course, stay healthy.